Okay, we are finished. Thanks God. I hope we met on exam. What about the examination card and examination task? Today we will for examination task. How it will be, what will be the how it will be. We check 4 or 5 examination tasks, how to answer. For example, 43 years old patient complained of a limited swelling in the right side of the face. What we know from this?
Limited abscess.
Abscess.
Limited swelling. Swelling limited. Where? Right side on the face. Then, anamnesis. The patient addressed to the doctor that a week ago there were pains in the tooth number 1.7. Upper jaw. Amplifying and touching to the tooth. The treatment was performed to the tooth number 1.7. Treatment was a few days after the treatment of tooth number 1.7, the pain in this tooth resumed. A swelling appeared in the upper part of the right cheek. Now we know from anamnesis was problem with the tooth 1.7 is the second molar upper jaw right side, was treated by therapeutic stomatologist. After a few days, start a swelling, pain continue, and start with the swelling on in the same region where localized second molar. Then the body temperature was 37 and 4. It's the inflammatory reaction. We know localized inflammation and general inflammation. When viewed below the zygomatic area of the right, there is a swelling. The skin over is thinner and hyperemic. With palpation, the swelling is painful, limited. The skin is not going to fold. It doesn't mean it's absolutely straight. Doesn't go to a fold when we touch it.
There is infiltration, there is
it's the exudation. Symptom about the infiltration, that it stretches now. A seal is determined up to 3 centimeters in diameter. The seal, I mean the fold, 3 centimeters in diameter. In the center, there is the focus of inflammatory situation with fluctuation. Purulent exudation
inside.
Opening the mouth is free. Understand why? Because it's the area who cannot touch the muscles, who control the open and the close the mouth. That's why no limitation of the mouth opening. The mucous membrane of the vestibular side of the mouth in the region of the upper molars of the right is a red color. During palpation, a broad cord extends to adjacent region of the cheek. Understand it, yes? When massing from the parotid duct, a transparent secret is obtained. Tooth number 1.7 is felt mobility of second degree and percussion is painful. Make a clinical diagnosis. First question. What we know now? It's the acute phase of inflammatory reaction. Was before the problem with the tooth. It doesn't mean that it's odontogenic inflammation. Acute phase, because it's short period, was treated, but now 4 days from anamnesis, we know. Where it's localized?
1.7
around the zygomatic bone area, cheek area, upper jaw, right side. The causing tooth, the odontogenic reason in the same area. Because you know, for example, if we have the problem with the upper teeth, we have the same problem with the lower teeth, but will be inflammation in the buccal or in the parotid or buccal area. We have 2 excess from odontogenic. There, it's typically like from the upper jaw. We found the reason of inflammatory situation. Now we need to understand which type of inflammation present. It's not the acute purulent periostitis. You remember how looks the patient with periostitis. It's localized inside. It's no focus of inflammation under the skin. It's not the osteomyelitis, because no clinical situation about the changes of alveolar process from the both side. Present mobility of the second degree, but we don't know, maybe was mobility before, maybe the patient has parodontitis or parodontosis when present the mobility. Now we know that we have these diseases. What we think, what if it's not the periostitis, it's not the osteomyelitis, it's not when massing from the parotid duct, a transparent secret is obtained. It's not the diseases of salivary gland.
And the swelling is limited.
Swelling from the skin limited. It's not diffuse. We now know that it's 3 centimeters in diameter in the center or focus of purulent exudation. It doesn't mean that it's abscess, not the phlegmon. Understand why? Why it's abscess of phlegmon? Because it's localized in the soft tissues. Understand it? What will be the final diagnosis? When you check the clinical symptom, you need to think about differential diagnosis. Why? We start with easy, we start with extraoral, continue with intraoral examination, and sometimes we need more information if we don't have from examination task about the X-ray. Here, we understand that the reason of these diseases is exacerbation of periodontitis or parodontitis. The tooth 1.7, understand it? Then local inflammatory process going deeper and start to produce the purulent exudation where? In the zygomatic area, closer to the skin. Understand the process, how to explain to yourself why it's not the periostitis, it's not the lymphadenitis, it's not the maxillary sinusitis, it's not the parotid gland, it's not the sialaginitis, it's not the osteomyelitis, it's abscess of phlegmon. Why it's abscess? It's localized,
limited,
and limited. We know straight the size of this purulent. Schedule a comprehensive treatment plan.
Tooth extraction.
Two treatment plan: conservative therapy and surgical therapy. Surgical therapy, incision.
Access?
Treatment plan, guys. Only one.
Incision.
Find the reason. Understand why? Then, what we should do with this? Extraction.
Upper 7.
In the same time to the parallel. Normally.
To the incision.
And the parallel we need to give surgical treatment. Yes. What will should be? What we should do with the patient? Operative access. Open the focus of inflammation.
drainage,
Where will be the flat inside oral cavity or outside, extraorally or intraorally? We have two types for this, for access. We prefer which one? Intraorally. Possible to open this
Yes,
space
because he haven't
intraorally.
inflammation.
Yes,
He
Yes,
has.
possible. We use the local anesthesia with sedation or general anesthesia. It depends on the condition of the patient. Then, how to open the zygomatic area?
From the end of the upper jaw, we find the line. We touch the bone, the face of the bone, and then I have the incision at the
from canine to third molar, it will be accessed parallel to the alveolar process for canine to premolars, three molars, 6 teeth. We cut to the bone, then we open it. It's a mucoperiosteal flap. It's full thickness. We need to open. Then we use, like you said, instrument to go deeper to open this. What will be the result? To understand that we have good access, you need to see the purulent exudation from incision. Then what we should do? Operate, okay, we forgot. Anesthesia, it's maybe local. Sedation or general anesthesia. Then operative access, irrigation. Then
Insert the
drainage.
to
Then
get rid of the purulent exudation. Then medical
No suture.
No suture, yeah.
understand it why? And we extract the causing tooth. Find odontogenic. It's the surgical treatment.
Second one.
Then
Conservative.
conservative. It's drug therapy.
Yes.
Antibacterial, antihistaminical, desintoxication. Then, locally what we should do, painkillers of course. We give it usually intramuscular injection. Painkillers, okay. Then,
Multivitamins. Curative spoon. Multivitamin?
why you need the curettage spoon? Where you can find from the conservative therapy curettage spoon? For the doctor, for the eating the ice cream after the operation? No. You use the curettage spoon when we need to extract the odontogenic reason. Of course, we use all steps of tooth extraction. Guys,
Immunotherapy.
we use the all steps of tooth extraction. Here, okay, we're using the excess, then we open full, then we need to go to the, because the flap design will be there, and the reason and the focus of inflammation there. You give deeper closure to the focus of inflammation. And we need to see it pass. It's the clinical symptom. It doesn't mean that you open right the abscess of ligmon. Then you irrigation with antiseptic solution. Then you put drainage, no sutures. No sutures. We discussed in which period we can give the sutures. After when finished, the purulent exudation.
Second
Inside oral cavity, no. If it will be intraoral access, we don't use the secondary suture. We use it only if was access from the skin. Why? Because the skin is the thick layers with the hair. You remember, with follicle of the hair. What happened? How to grow the skin? Like this one, from outside growing
to inside.
when it's touched. What happened on this? For example, it's the skin here going down, then touches inside, and here the granulating tissue. When they meet together, it will be growing to the right position. But this will be the scar, because the granulating tissue transform to the scar formation. This is the reason why we use the secondary sutures to create this direction of the skin, that it will be like this, not like this one. It's like the prophylaxis of the scar formation. Scar formation, the big problem, which not good, well, because it's without pigment. without good nutrition. It looks palely, that real skin. And in the scar, no fibers to structures. It's the hard structures without elastic fibers inside. And when the patient, for example, open, it will be like the limitation. Understand it? Sometimes we use secondary, for example, was huge inflammation, like the phlegmon of the floor of the mouth. You saw how it looks on TV. We saw it. What will be the picture of the operative access from angle to the angle. Of course, we need to use it because the patient has limitation of the movement of the hair. Why? Because if it stretches, you remember how we need that the muscles and the skin has the stretchers. It helps to change the configuration. If it will be hard, the patient feels the limitation of the movements. Why we use the secondary sutures? It's only if it will be extra oral excess. Please, I can ask you on exam where and why we can use the secondary sutures. If you have this the clinical situation, for example, task about it, I can ask you about how it possible and why it possible. How to answer. When stop the purulent exudation, we can do it to prophylaxis the scar formation. Understand it why? Okay. Conservative therapy continue. Antibacterial, antihistaminical, desintoxication, painkillers, and local antiseptic therapy. What does it mean?
Irrigation.
We use irrigation 2 to 3 times a day. We need to clean it, to change the drainage. Yes, we put the drainage and we need to change it ideally 2 to 3 times a day. Why? Drainage is like a tube. It's the same foreign bodies inside the flap, but we need it because we need to open that all secretion going from the focus of inflammation outside. Why we need to change it? Drainage can apply to yourself the cells of purulent, the microbes. And it's like the foreign bodies, like a stimulation, the same locally inflammation. Why we need to clean it and to change to the new one. Ideally 2 to 3 times a day. It depends, of course, on the condition of the secretion, but ideally this one. In some books, you can read that we have a special irrigation, like a mechanical irrigation. It's like the tube fixed with the sutures, and it's the active irrigation. We use a special mechanical apparatus. We put 2 tubes to this one irrigate, second section from this. Usually we use it if the patient has mediastinitis, because you remember the excess for this one, and finally where will be the length of the drainage. Why we don't change it? We use the active aspiration system for drainage. For how many days antibacterial therapy?
7 days.
14 days.
10 to 14.
2 weeks.
Desintoxication therapy depends, but usually 3 to 5 days. Painkillers.
Until the patient was
Depends.
Depends on the situation.
3 to 5 days. Usually it's around 1 week. It depends on the access. Limitation, full, intraoral, extraoral. This before finish. Purulent exudation. When purulent exudation finished, we can use 1 to 2 days more for clean this area. But if no purulent exudation. It's the rule, we need to take away the drainage. If we take away the drainage, how to clean inside? It's impossible. You can use the local antiseptic irrigation for the skin only. Understand it? Not inside. Or if it's okay, we take away the drainage and was intraoral excess, we can prescribe the antiseptic irrigation of the mouth, like usually 2 times a day with chlorhexidine, like the patient did after tooth brushing. Oral hygiene was from start to end. Understand why? How eat? Question usually from the student. How to patient eat? You know that we have a special diet by Pevsner. Maybe you hear from the internal diseases. Pevsner, it's the doctor who create some diet, and the diet depends with which problems. It's the diet for the patient who hospitalized with the problem. For example, patient has diabetes. They need to eat every 3.5-4 hours. You know it. Small portion. If the patient stay at the big hospital with diabetes, then prescribe it because it's need for this patient. The same patient in the one room, how could it? Sorry. The patient with the one, for example, problem. For example, with osteomyelitis. One patient has diabetes, other patient don't have the diabetes. But patient has the limitation of the mouth opening. Does it mean that they cannot eat the big pieces of the food? They use a special diet. This diet number 1 or 2. It's like the porridge.
Yes, nice.
And the meat and the oil, it's like the porridge. It looks like the how it said, like a smoothie. Or like a smoothie. Yes, it's liquid.
Картошка пюре.
Like a puree, yes. I hate a potato. My husband loves, I hate it. I don't understand the taste of the potato. It's like the nothing. Meat is perfect.
احنا عايشين عليها.
Yes, okay. And the same, if the patient cannot eat, we prescribe the special diet. It's not the same like the patient can eat. And of course, when the patient finish the limitation of the mouth opening, for example, patient can chewing, we can change the diet too. Because the patient 100% 10 days will be at the Maxillofacial Surgery department. What do you think? On this case, we don't have the limitation of the mouth because it's a zygomatic area. If the patient has limitation of the mouth opening, we treat it perfectly. We extract the causing tooth. We use the flap design. We prescribe this one. Perfect, good contact with you, using your recommendation. You control the patient 2 to 3 times a day. You discuss how it will be. In which day finished the limitation of the mouth opening? What do you think? How many days we need to control?
7 days or 1?
After finishing all
For
conservative.
example, patient has limitation. Maximum patient open and the size between the incisor about
2 millimeters.
5 to 7 millimeters. How to control that this limitation finished? You check the patient every day. You understand, change the situation, or it's the same like was before. How to understand it? Ideally, how many days we need that the general organism, the computer, finished the inflammation with your helps?
1 1 week, 7 days.
From 7 to 10 days.
When he finished.
First difference
The antibiotic.
will be after 4 days. Why? Because we have the full answer about antibacterial therapy. Understand why? Yes. Finished purulent exudation, ideally, yeah? And the muscles feel the better. Why? Because the macrocirculation
Starts.
Increase.
starts like not normally, but bigger than was previous. And the pH of acid, you remember, because it's purulent exudation, is the acid reaction. Finished. If no acid inside, what happened with the muscles?
Constrict.
Yes, and the macrocirculation.
Go.
And yes, and finishing the edema of the muscles fibers, and we have the more,
Opening.
Maximum opening.
Opening.
not for the maximum, but it's bigger like was before. It's not ideally, but bigger. How to control antibacterial therapy? 2 or 3 types from the other group. It's not the monotherapy. For example, macrolides and cephalosporins, macrolides and penicillins, penicillins or cephalosporins. Where will be said if the patient, what had, you know, we discussed it, what happened, what patient had, where we can prescribe another one, antibiotic, said one.
Have resistance?
Allergic.
No,
Have resistance?
only one reason,
Which?
No. which is absolutely different therapy.
تقول انت بنستخدم الثالث.
HIV therapy, the patient has therapy for HIV, immunocomprehensive therapy, and we can use only 2 types of antibacterial therapy. It's the like Cladcid and Rulid is the antibiotics reserve from the reserve group. We start with these antibiotics immediately, and we prescribe the metronidazole too, because the patient has opportunity infections, systemic. In which time we prescribe the said antibacterial therapy. From one examination task, we have clinical picture. Patient was hospitalized with phlegmon of the submandibular area. Was treated at the hospital, was prescribed antibacterial therapy. After 2 days after operation, patient has exacerbation of inflammation and inflammatory, change the direction and closure, change the localization, and going deeper to the pterygomandibular area and to the submandibular area. What was wrong? Was antibacterial therapy prescribed in the right, how many times, but one clinical symptom, if you touches the muscles and you feel, I said it, not only one, and you feel, we discussed it the last week, and you feel like crepitation,
Yes.
what does it mean?
كريبيتيشن يعني في بولز وحاجات زي
If only one reason when you prescribe 3 different types of the antibacterial therapy, if the patient has an aerobic, how to control it? Sometimes it's impossible to control because we see the patient only now. We don't see it before, and we see from this time to next day, next day, next day. How to control? Of course, the crepitation for anaerobic infection very good when we prescribe this one, because we kills the normal microflora who said now not normal, And when the normal microflora dead, anaerobic has big field to uncontrolled producing. Understand what I mean? Why we use, when we use the operative access, the test, the name of the test, we take a test for not biopsy.
Cytology.
Cytology.
Why?
To know the bacteria to prescribe the right
Yes.
therapy.
But we have the results of this test from how many days?
40,
2 days.
48 hours.
4 days.
Cytological
2 days.
examination.
2 days.
Bacterioscopic, we can find when you check from the laboratory the result, you can check the names of bacteria, who there, who stimulates the inflammatory process. This is the answer about
How would you treat it?
Treatment.
First card.
about the treatment. How to treat it? You remember, in last semester we discussed how to answer on this, how to answer on this. This all answer. It's only one answer for all abscess and phlegmons. Why? We have the same rules. Different will be only
قلت لكم ما ثبت التريتمنت.
operative access.
Depends on the site.
All the same. It doesn't matter up, low, jaw. Difference if anaerobic. We prescribe 3 times.
Precipitation.
Desintoxication the same. Of course, if it's a phlegmon of the mouth of the floor, desintoxication therapy will be bigger. It's about 7 days because it's huge inflammation. Understand?
So if it's anaerobic, we will just
3 different groups. We prescribe this, and one for anaerobic. Which type of anaerobic you can check on the test result,
Cytological.
on cytological, yeah. By the microscopic test. You can find laboratories, sometimes how we work with laboratory. We take the test and write the name,
The
which
type of
name and which antibiotics prefer. The laboratory test is it's like the round form, and this is the name of a bacteria. And then use the antibiotics to control. And for example, this one and this one, we take 2, and we have the rule. It's the same. They put it, and usually the microbes like across, it's the same antibacterial therapy. It's like the result of the test. Of course, anaerobic is absolutely different. But why we prescribe 2? To start immediately.
Because maybe it can adapt to the antibiotic.
Yes, because sometimes it's not enough. We don't understand that it was anaerobic. And then when we check, but we use this one, then we immediately to take another one. Of course, it's all intramuscular or intramuscular. Patient cannot eat the tablet. Why we don't prescribe the tablet form? Patient cannot eat, cannot drink. It's impossible to regenerate from the gastrointestinal tract, unfortunately. It's the scheme for all
We should say
answers.
about the blood analysis we should repeat it first.
Yes.
Third,
If you have from the clinical the question about how to control your therapy. When the patient meets with you, we take the blood
test first.
analysis, yes. Then we can check leukocytes. Leukocytes raw consist of young and the adult. Adult так, young, по-моему, так. Да. Да. Yes. Younger adult cells. Adult cells, the name of the adult cells.
Leukocytes?
Leukocytes raw is the summary name of all leukocytes cells.
Xenophils или basophils
Yes. Young cells is basophils, ionophils,
Neutrophils,
and
Neutrophils.
сегменtoядерные, не знаю, как сегменты. We have 4. And if the patient, of course, we have leukocytosis. And how many normally leukocytes? What does mean 5? Five cells.
Normally
1, 2, 3, 4, 5.
Normally
5 cells. For how many? We discussed that you need to check the normal blood analysis because in some examination task you have the blood analysis. Hemoglobins, leukocytes, erythrocytes, thrombocytes.
The percentage. How
Yes,
it's
the
normal.
percent. Yes, and you need to analyze it.
It's
Where is it? Higher, lower, normal? How to treat the patient? We discussed why we need to know the normal components, from the blood analysis. Leukocytes, erythrocytes, thrombocytes, what else?
Xenophils, erythrocytes.
No. The normal cells, erythrocytes,
Platelets,
leukocytes,
platelets.
thrombocytes, and
Platelets, lymphocytes, platelets.
adult is the
عشان نشوف
neutrophils. No, we discussed the blood analysis formula. I mean, which cells we need to control.
hemoglobin.
And hemoglobin, yes,
It's important.
and C-reactive protein,
Monocytes,
and
phagocytes,
what about the speed of erythrocytes? What's the name of this?
speed.
Of erythrocytes. Yes.
ASR. جدع والله العظيم والله كنت عارف.
What's the normally numbers of this?
ASR.
Early was from 4 to 6. Now 6 to 10 normally. Of course, different men, woman, young, but in the middle. How normally leukocytes cells? Yes. 5. We're going together, and we will be cells from one adult, from one
from,
adult man, for
1,000.
example. How many?
From 4,000 to
From 5,000 to
11,000 per
10,000
millimeter.
millimeter.
Not 5.
Leukocytes.
For children or all adults.
In which?
Adults.
9.
Leukocytosis, how many? It's the normal. What does it mean, leukocytosis? How many? Leukocytosis.
Больше, чем
6
надо.
and 5, 2. It's a leukocytosis.
More than
More.
than.
How many more?
How many?
6?
5.
5?
No.
In periostitis, leukocytosis will be
12,000
in osteomyelitis. Abscess and phlegmon is huge. It's about which one? It's maybe 20, maybe 30. Why? We need to understand which cells prefer inside the leukocytosis. Because if it will be adult cells more, patient has cancer. It's a tumor change the blood producing. No young, because the cancer eats the young cells, you know it. And and more adult. In the components, it's more than 65-70% of adult, and only 20% or 10 of young. If we have inflammatory situation, it's opposite. It's only 10 to 15% adult, 80% of young. Why we need to control it? We prescribe this. We do this. We need to understand that this change, it decrease to the normal, not from the next day, but it components inside change like normally. Why only young cells more? Inflammation start, going and eat normal tissues, eating. The brain control and take from the organs cells to producing. How to cells produce? Start with young, and we need a time that young cells growing to the adult. How many days usually? It's more than 4. We don't have a time. And the computer produce more young. And this young going to help the lady from the virus or from the bacteria, to kill the bacteria, to eat the product of it. Why? Because if not enough general cells who can eat the virus, the organism produce young who can stabilize on this area when the young cells growing to the adult. Understand it? And then we need to understand that now, normally situation, that young cells has time to produce to adult and decrease the inflammation. Understand? The same erythrocytes, thrombocytes, C-reactive proteins, normally no, 0 in urine, in blood analysis. If we have inflammation, we have C proteins, 5, 10, 15, it's huge. What is it, C protein?
C-reactive protein.
C-reactive protein, what is it? What's the function of C-reactive proteins? What's the nature of this? Where are they present? And why? Only on inflammatory process present. What's the function of C-reactive proteins? In internal diseases, so far.
It's a sign of inflammation.
Why?
Results
To
to sign of
recognize
inflammation.
It's a result of inflammation. Or C-reactive proteins helps to decrease the inflammation.
To
Why they start to produce? What's the nature of C-reactive protein? C-reactive protein present if the patient has arthritis. If the patient has hepatitis.
inflammation.
If the patient has myocarditis.
Titus.
Why? It's all inflammation. It's the like for us, like a signal that the patient has inflammation. Normally, C-reactive proteins produce in the body.
No.
if there is
Just
no inflammation.
if there is just
Produce just in case of inflammation.
Yes, because it's signal. It's like the
But it's destroyed. It's too small and destroyed by the leukocytes. Because inflammation always present. We're talking by each other. The microbes from the air going to my body fight. My microbes fight with other microbes. You eat the food. The microbes inside too. The microorganism with microbes fight in the gastrointestinal tract, of course, with special from the gastrointestinal tract we have what? HEPA produce yellow liquid.
Bile, yellow liquid bile.
This helps to destroy the food by the small pieces.
Digestive.
Then secretion of the H. Yes, this destroyed for full and no, it's not this one. We now in the gastro, not in the yes. The same. We have a special parts from the blood analysis to analyze the type of inflammation and the type of inflammation. Hemoglobin, how normally? Why the hemoglobin decreased?
because
Because the erythrocytes decrease too. The quantity of erythrocyte decrease. Why? General inflammation, pH acid always. The product of inflammation destroyed the normal function of breathing and hemoglobin production. Interesting. This all together. Patient cannot discuss with you because patient cannot talk. For example, the patient has phlegmon of the mouth or the floor. We take the blood analysis. We analyze the condition situation. And for this, and for this, we can understand how many days. And how to prescribe the right this. It's easy to understand. If you understand the structure, it's like step by step. It's answer for each clinical situation task. Because you have only situation task for abscess and phlegmon and for the fracture. That's all. About the fracture, we check. Yes.
About our case, we have certain degree of tooth mobility. Why did the dentist do root canal treatment in second degree? Why?
Who knows?
So it's the fault of.
Maybe it was the exacerbation of chronic periodontitis, or maybe acute periodontitis.
But second degree of tooth mobility can't happen in 4 days.
Maybe it was stage, maybe it was first stage of degree. But if the inflammation is so huge and patient has systemic diseases, the mobility can change immediately. Because when starts the producing the purulent exudation is destroyed. Why after 1 day the patient, if the patient has osteomyelitis, the tooth, causing tooth has a second or third stage of degree, it's immediately 1 or 2 days, then 5 days. Purulent exudation destroyed and going deeper. Maybe was destroyed before. Maybe the patient has parodontosis, when the mobility present. It's not like a physiology mobility, but when change the level of the bone, why present mobility? We have 2 types of diseases. Can I? Why present mobility in osteomyelitis. What happened? We have changes inside the bone, destroyed the ligament part, yeah? When changes the thickness of the bone, because present the edema and swelling from the both sides of alveolar process, change the nutrition. Why present the mobility inside and outside? When destroyed the round ligament, mobility starts immediately. Then only the time. The time depends on the condition of the patient, on the plaque. It's maybe 1, 2, 3, 4 days, and we have the mobility of the second and the third stage. Why we don't have mobility in periodontitis? Chronic. You remember, chronic periodontitis, no mobility. Acute periosteitis, no mobility. Lymphadenitis, no mobility. Maxillary sinusitis, no mobility. Why? Maybe patient has big cyst, like this one, more than 10 millimeter in diameter, but no mobility. Why? Because saved the round ligament. Round ligament, only one ligament who stabilizes by vertically. Control the mobility, control the pressure to adequate pressure, to adequate mobility for the chewing pressure. It's the round. If it's destroyed, patient has mobility. Periodontitis. Why present mobility in periodontitis? When lost the forming the pocket formation, start with destroyed the round ligament. Immediately start the mobility. Of course, the other part of the ligament stabilize, but when destroyed the round, on microflora flowing deeper, forming the plaque inside, and then destroy this one. It's the same situation. No round ligament, no present mobility, vertical mobility. Saved the ligament in periodontitis. No mobility. Destruction big, but no mobility. Here, saved tooth, healthy, no feeling, no nothing. No this focus of inflammation, but pocket formation, mobility. This is the difference between two types of diseases. Now, by international classification, we have only one. We don't have periodontitis and parodontitis and parodontosis. We have all periodontitis with loss of the bone around the apex, with loss of the bone, this one, with pocket formation. We discussed was 2 or 3 weeks ago was the big conference about the Nizhegorодskaya stomatology. It was 100 years, and was the professor from the other countries, from the Belarus, from the Kazakhstan, and from the some region by the Russian. They take absolutely different terminology. They use like the American classification, because we have only one, periodontitis. But in Russia, typically we separate it for other groups, because the mechanism of destroying the bone absolutely different. Patients don't have periodontitis, I mean the destruction around the apex, but patient has diabetes, hypertension, patient has parodontitis. It's from the main body, it's no control, plaque change, microflora change, and start from the upper to inside. Periodontitis start with apex and continue to the crown. It's a different direction and absolutely different type of therapy. Unfortunately, now maybe for us, unfortunately, because it's like a mix, it's like a salad inside your brain. What does it mean, periodontitis? When we see the slide, we treated the periodontitis, then the general periodontitis. We saw like this, interesting. And one professor said, we forgot all terminology and we don't understand which right terminology. Now in Russia, typically 3 periodontitis with 3 group acute, chronical and exacerbation of chronical, and parodontitis. Parodontitis is with acute inflammation. We have local and diffuse or general parodontitis. We have parodontosis, when no mobility of the tooth, but no bone. It's maybe open the part of the root, the gum level like this one, it's the crown, it's the cementum, but no mobility. It's the parodontosis. It's the absolutely different reason. Parodontitis, itis, is the inflammation. Parodontosis, O's, it doesn't mean that no normal nutrition there, but no inflammation. We lost the bone because not normal nutrition there. And sometimes the tooth only on the apex, this free without gum. You touch it, no mobility, because no inflammation. In parodontitis, the gum may be like this, but the pocket formation deeper and the patient has mobility severe with the bleeding, with nothing. When you saw the patient with parodontosis, teeth, the root is open from both sides, but no complaints of the patient, no bleeding at the tooth brushing, no inflammation there. When it starts, patient asks, what start? When start they open the root, patient, I don't know, because no complaints, no inflammation. In parodontitis, inflammatory process start immediately, and all complaints of the patient. Bleeding when the tooth brushing, when the irrigation, look at the bus and see the blood real, or feel the blood test smell inside the nose. This is and the mobility, of course. How to patient understand that present mobility? Patient feel the movements deeper on the chewing first, and patient thought that now it's not the same bite like was previous, because the tooth has changed the direction. Of course, first tooth or teeth who suffered is the central, because it's lower jaw, central incisor, short roots, very thin bone. And the pressure like this, and the upper jaw cut, this take from the cut, and the first movements of the chewing, this one. This is the problem. Understand what the difference?
Yes.
What is the treatment for the parodontosis?
Parodontosis, we need to understand the general situation, the general condition. Usually no therapy. We can prescribe the, not like a surgeon, like a stomatologist, but the therapist doctors can prescribe the vitamins, prescribe the medicine always stimulates the muscle circulation. But if we lost the bone, sometimes we can use the bone grafting procedure. But if the nutrition and muscle circulation deeper, the results, decrease, yes. The results of bone grafting procedure like 0. Usually how we can help, if the bone is safe for good size, we can take 4 implants and did the all on 4, for example, like this. Sometimes it's impossible, and we save the teeth long time. Prophylaxis, only the tooth brushing, and that's all. because it's impossible to create new because it's the general. It's not usually in maxillofacial region. Some patient has arthrosis of the joint, and it's the systemic diseases if it's parodontosis. Sometimes it starts when the patient changes the region of life. For example, they birth in Sibir, now they live in Sochi. That was, yes, cold, absolutely different speed of regeneration. They change to the hot, speed cannot change immediately. They need time. Sometimes if you change the place of life for the body needs more than 2.5 or 3 years to stabilize, because patient feel headache, change the blood pressure, and who can control it? Patient thought that normally, but in the parallel start absolutely different process, and usually it happened. Yeah. Difference. Time of disease. We start with abscess. Understand?
Yes.
Then general condition. Satisfaction. Here. Not. What does it mean? General condition. General condition consists of 3. Temperature, then change the configuration, and loss of the function. If it will be, you know that we have 2 types, superficial and the deep.
Yes.
Abscess and phlegmon, the same, will be superficial and the deep. Temperature will be on the phlegmon. In abscess, we have changed the temperature between the morning and between the night. At the night time, higher. At the morning, lower. In the phlegmon, the same. One direction more than. First, lost the teeth. Temperature, change of configuration. In abscess and phlegmon depends deep or superficial localization. In abscess, the skin can change the direction. Can. In phlegmon, impossible. They stretch us for maximum. In abscess, in phlegmon, present the same focus of inflammation. In abscess, it's localized. In phlegmon, diffuse. Loss of function, the same, depends which type of superficial or deep. In abscess, change the function, usually 1. Open and close, or cannot change the direction. In phlegmon, maybe change the taste of the food. It's like, how it said, not, как это сказать, нарушение. Нет, это одно слово, есть медицинский термин, я забыла, как он называется. Извращение вкуса. No. That the food, it's not the same taste like worse. For example, they eat orange and feel it's like a potato. They eat the bread and feels like nothing. Извращение вкуса. Сейчас я найду. Как это? It's the terminology.
Dysfunctional taste.
Извращение вкуса. Дисгипсия, это по-русски. Дисгипсия. It's like the change, the change
You just feel
Dysgeusia.
and you feel like when you're eating
Dysgeusia is, it doesn't mean that it's the food change, the taste, the smell, the taste
Yeah.
is the difference.
And you
Okay.
feel you eat
Yes, and
As you
you
feel
feel
before.
like they eat nothing
or something else.
or something like this. Yes. Or for example, you drink a milk and you thought that it's like a Coca-Cola, for example. It's because the for example, patient has phlegmon of the mouth or phlegmon of the tongue. The the analyze of what is it finished, because change the superficial layers. It's the plaque, for example, on the tongue. Patient cannot eat, cannot drink, and how it said, change the soft structure, change the normal position, and the food different structures by the previous organs, like it was before, like it was normally. And this is dysgeusia. Дисгефсия, она так и есть у нас по-русски, дисгефсия, мы так и говорим. Извращение вкуса. And loss of function. What's the loss of function? Cannot drink, cannot eat, change the function, change the taste, and lose the function. If the patient has, for example, the phlegmon of the floor of the mouth, the tongue change the direction, its closer to the throat. Patient has special position. What does it mean? If the patient sits like this, it's better for the patient. Why? The tongue deeper there to the center, and the tongue has space under the tongue without between the throat and between the tongue has space. This position, patient better. If the patient changes the direction like this or like this, patient immediately feel like the asphyxia. It's the change the function. Understand what I mean? It's only if the patient has phlegmon of the floor of the mouth or phlegmon of the tongue, because it's diffuse inflammatory situation. The difference in the blood cells, in the blood analysis.
الحوار ده
Slightly change in abscess, more changes in phlegmon. It's about leukocytosis, about the hemoglobin, about the C protein. Clinically, patient look the same if the patient has superficial position of the abscess and phlegmon. Difference in the area. Abscess localized, phlegmon diffuse. You can see in abscess straight the area with hyperemia, like round, like oval, but you can see straight the bodies, the form. It's limitation. It's limited, yes. If it's phlegmon and diffuse, you can see more hyperemic, slightly hyperemic, more hyperemic, slightly hyperemic, but no straight borders between the hyperemic and between the normal color of the skin. About the turgor, about possible to take in phlegmon, impossible to stretches the area of changes. Temperature, lost function, blood analysis. This all how to differential diagnose.
How about how the patient looks?
And the time of diseases. Very important.
How the patient look?
What does it mean? Configuration change. All the same configuration change, but difference, it's more changes in phlegmon. More changes in phlegmon.
Doctor, the questions have we have phlegmon in sublingual area and abscess in sublingual area. How we can answer these answers?
Yes, of course. The changes you answer the same. In abscess is localized, in phlegmon is diffuse. More hyperemic in phlegmon than abscess. When you palpate in abscess, you can find the focus of inflammation straight with the right focus bodies. In phlegmon, no, it looks like all inside. And the same change the position of the tongue, you know it, about the time of diseases and this one. Clinically, it will be the same.
In all questions like that.
Yes, absolutely. It's the same. You have only one big problem to understand that answer, it will be the same. It doesn't matter, abscess or phlegmon. 28 years old, was admitted to the clinic with complaints of the pain in the body of the lower jaw on the right, swelling of the soft tissues on the face on the right. Now we know patient go to the clinic because patient has complaints with the pain and the change and the swelling on the of soft tissue on the lower jaw, right side. Anamnesis of diseases. According to the patient, 2 days ago in the evening, he was beaten by unknown persons, did not lose consequences, did not seek medical help. Now we know the time of diseases, 2 days. Was trauma. Maybe the men discuss about what prefer apple juice or orange juice. Transferred and contaminant diseases. 2 years ago, suffered viral hepatitis B. Objectively, general condition of moderate severity, body temperature 37 and 2. Facial asymmetry due to collateral edema of the soft tissue of the buccal and submandibular areas on the right. Understand, yes? The skin is not changed in color. Palpation of the tissue of the maxillofacial region determines the symptom of a step in the area of the lower jaw body on the right. Submandibular lymph nodes on the right are enlarged 1 centimeter, sharply painful on palpation. The opening of the mouth is limited to 2 centimeters and the pain under the opening. The mucous membrane of the alveolar process is determined in the oral cavity in the area of 4.7 teeth with a slight hemorrhagic discharge. 4.7 mobility. First degree, percussion is accompanied by sharp pain. Make a diagnosis of the underlying dental disease.
Dental disease.
Patient has 2 days ago trauma. Now no treatment, no nothing. Now patient has limitation of the mouth opening and the pain in the tooth 4.7 is the second molar, lower jaw, right side. When we palpate the man, we understand that palpate like a step. We remember the OPG we discussed. Yes? What does it mean, this step? Then body change the level and change the new position. This step doesn't mean it's not like normally like from the other side and change the normal lower line. What we know more? Lymph nodes, of course, lymphadenitis was trauma, inflammatory process start. No, for 2 days nothing, I mean no therapy. Of course, lymphadenitis will be. Tooth 4.7 has mobility and percussion is accompanied by sharp pain. If the same area, we palpate the step. The jaw. Is the fracture of the lower jaw single?
Two
Why
fractures.
present mobility? Because the fracture
Because the
line
fracture
through to
through
the
the
socket
socket.
of the
teeth
second
4.7.
molar. What we should do?
Extraction.
Extract this tooth and do
Because
splint.
from body inside.
Make a treatment plan
Dental.
Splint.
for dental disease. Which type of therapy we can prescribe? First of all,
Splint. Observatory.
we need to
X-ray.
find something new because now we understand that the fracture is the open type because we can see under the gum hemorrhage. It doesn't mean that the soft tissue slightly destroyed and hemorrhage on this the same area like 4.7. Understand what I mean? Why present mobility? It may be first, second, third degree because tooth in the area of the line of fracture. It's not inside for full socket. Understand it? What we need to find? We don't know about what was the trauma. Patient said what was discussing with other men by the hook, but who knows? Patient said, yes, no consequences, but how to know it? We need to find more symptoms. If on the face, no hematoma, no injuries of the soft tissues, we need to see X-ray. Because if it was like this one, you remember how the pressure in the from the other side in the temporomandibular joint. Which type of X-ray we need to use?
External X-ray.
OPG. First, we need to check, and then usually we prefer the second one because we can see all structures.
Hard structure.
Yes, or MRI, what you want. It doesn't matter because we need to find full structures in maxillofacial area.
But for the
You-
OPG, that will be the lateral OPG.
No, it's panoramic.
Panoramic.
Panoramic, yes.
But
We
you will not see this part.
yes, we not see, but we think we saw the patient. We touch all. We understand that we have only one fractured line. We start with this. If it's impossible to do this and this, we start with this. If we have this and this in the clinic, we start with this. We don't need the OPG because we can find all hard structures in the MRI or CT scan. Then, what we should do? What does it mean? Treatment plan. First, X-ray. Second, final diagnosis. Third, we need to use conservative. We start with conservative. What does it mean? We need to understand which technique we can use for reposition and for the fix with right position. If we understand from X-ray that we need to extract the second molar, we don't have third molar. Possible to use splinting technique only? No, we use splinting technique, but we're planning. Conservative, it's a splint. Surgical, yes. Because we need to reposition to the right position and fix
With the screw.
with the screws. Understand it? If will be the third molar, for example, we can use only splint,
To
but we
represent.
need to remove the second molar because the second molar is the line of fracture. It like a foreign bodies because when the line of the fracture has position inside the socket, the root usually between
Bifurcation.
in bifurcation zone, it's the softer zone, and it doesn't mean that the tooth fix, but you cannot reposit because the tooth change
it
inside
inside.
the socket position, and this is like a foreign body to reposit to the right position. That's why we remove the second molar. If it's possible without to reposit, yes, it's no problem, but usually it's impossible, especially if the tooth has mobility. It doesn't mean it's maybe the fracture of the root of the causing tooth or the dislocation of the tooth. Dislocation is like a result of fracture from the socket. Understand? Conservative splint, then surgical for this type, then of course no. Surgical is osteosynthesis. No, general therapy. They say antibacterial, antihistaminical, physiotherapy we can use, and very important to the fracture. Yes. Why? Because patient. I'm afraid. Teacher did in the classroom. The reason of that's the table. Okay. Joke, okay, smile. Yes, why very important the oral hygiene? It doesn't matter will be surgical osteosynthesis or not will be. We use the splinting technique. Splint for all for both jaw, for the upper and for the lower. Patient has limitation of the mouth opening, but you give another foreign bodies in the oral cavity. No spaces. Why? Applicated. Why the soft plug applied the splint? Because it's like the foreign bodies. You know it. And we need to clean it every day, 2 times a day. How it works? Usually patient first 3 to 4 days using only the toothbrushing vestibulary and the irrigation with chlorhexidine 2 times or 3 times a day. Then when yes, possible. Patient don't have 1 tooth, second molar. From the second molar, we can use the toothbrush. You sort the toothbrush for the bracket.
Interdent brush.
Yes, for the tooth.
Yes.
Has the angulation and small. We have the same for cleaning from the socket of the second molar, the jaw, because jaw closed and fixed with the elastic part. For how many days?
The general.
How many is what?
This.
It's like the same, like
2 weeks. 2 weeks.
Antihistaminic, the same. Physiotherapy we start after, when we finish surgical, after 5 to 10 days. Yes, yes.
to have what?
We can use physiotherapy, it's like a laser therapy, only for macrocirculation, yes, it's for the muscles and for the regenerate. Because the edema inside will be, and we need to stimulate the macrocirculation to decrease the edema, to start the action of vessels, to regenerate stage, to regenerate stage. We prescribe physiotherapy usually 1 time a day or 1 day, and the procedure 3 or 5. It depends on which physiotherapy we can use. Laser we can use 4 times. 1 time a day 4 days, or the day after the day. For example, Monday, Tuesday no, Thursday yes, there's no, Friday yes, there's no, Saturday yes, and the Monday no, Tuesday yes.
And
It's like this.
is there laser? It's like
Laser, it's like the superficial, it's the special apparatus. We fix it. It's only for stimulate the macrocirculation. No temperature change, no nothing change. It's only for macrocirculation. Or now we can use инфракрасная термометрия, инфракрасная, не знаю как по-английски. We use the right
red lights.
red lights, yes, we can use the red lights. It's the same stimulation of macrocirculation. It's the same, usually 3 to 5 minutes for the area when was trauma, extraorally, I mean, from the skin, and the same 3 to 5 procedures.
and the physiotherapy just lasers and other types.
We prefer only laser, yes, it's enough. In some literature you can find that you can use ionophorese with calcium, with lidazo, or with like this. No, it doesn't work.
Laser.
Very good working when you finished to fix, yes. When you fix the 2 broken jaws part, it's perfectly, because immediately start regeneration, yes. No movements, and it's like the same area connection with the same area from the broken parts, other broken parts. It helps to protect because it's closure, and it starts immediately growing the vessels inside 2 parts of broken jaws. What about the conservative splint? Splint patient for 4 weeks, 28 or 35 days. It depends from one side, from both sides, fractured line, and surgically for all life. We don't remove the osteosynthesis plastin after, especially if we use it, yes, in the condylar process. We fix it for all life. Usually we can use the mini screw for fix, or we can use the long splint like this inside.
That will be for adults, but for the children, we should.
For the children, it's a very big problem because all fractured of the jaw stop the jaw growing. And usually if the child has the fractured, it's stop and growing not symmetrically from right to left side. And we have in
Even with the growth hormone, for example, it's not good.
it doesn't work, unfortunately, yes. We prefer the osteosynthesis, but we need to use secondary to take away this plastin, yes, because the plastin stopping the growing, yes. Yes, that's the big problem. It's the same, it doesn't matter, it's a jaw, it's maybe leg, it's the same problem in the child. Yes?
We use medicaments for bone regeneration or no?
No.
Maybe we can.
What do you mean medical regeneration? What do you mean medical? We, okay, yes, of course. Yes, of course. But it starts to growing immediately. Both start to grow immediately. After 14 days, here like a cartilage. Then mineralization time from 3 to 6 months. When you take away the splint, you can prescribe calcium if you want. But it's start after, you can prescribe it after 1.5 months after trauma. Polyvitamins, okay, it's no problem. A, E, what you want. B group for regenerate the nerve. But for the normal bone regeneration, enough to fix to the right position and to stabilize without function. I mean, without pressure, that no mobility, it will be enough. It works like the bone grafting procedure. When we take the bone from here and fix from here. We don't prescribe the calcium or something like this. It's by the nature. It works by the nature mechanism. If you want, okay, it's no problem. But it's no need really. If the patient has systemic diseases or something like this, yes, we prescribe. But normally, no, it doesn't work. What we prescribe 100%, the oral hygiene. It's more important because the soft structure, I mean the mucoperiosteal thickness, is too thin. And if no normal level of the microflora, it doesn't mean that the plaque, infection, it will be infected from the oral cavity to deeper to the fractured part. Why very important to understand the patient why we need to use the oral hygiene. It's hard to answer for all fracture. Understand it?
Yes.
I can ask you which type of antibacterial therapy we prefer. From which pharmacological group? We prefer penicillins and macrolides. Is good better than other. Usually we prescribe one time. The same injection, intramuscular or intravenous, because patient close the mouth. It's impossible to use the tablets or capsules.
The normal opening of the mouth is 5 centimeters.
4.5, 5, it depends. Usually 4.5, yes, it's normally. More than 4.5, it's the hyper. It doesn't mean that the patient has problem with ligaments. And it's not normally, we need to fix it. Because upper, more space inside and more pressure to the disc. Because how it's open more, it doesn't mean that the deeper, closer to middle, here, but it's too deeper. We need that it will be only for this. If it's deeper here, the road of the length deeper, and it's too high pressure to the cartilage. It's not normal. But some patient has hyperactivity. Maybe you saw the patient who has yes, like this one. It's the diseases of significant ткани. It's the diseases of tissue. It's the systemic diseases. It's like hyperaction of the joint, hyperaction of the function. It's not good. Yes. It doesn't mean that it's too elastic. We're not typically elastic. And usually in the, when the patient will be after 15, it starts like the arthrosis.
Doctor, this is a way of treatment for upper and lower jaw?
It doesn't matter.
Fracture.
It's the same. Difference only the split, I mean the conservative, or we need conservative and surgical therapy. And the surgical depends where it will be, in one direction, in next direction, yes. Answer for all. It's like the step by step what we should do to understand if the patient has other injuries of soft tissue, for example. We use the suture with the plastic, plastic effect, not effect, with the cosmetic and plastic effect immediately. Because yes, in the same, not only the suture, but if the patient lost small pieces, for example, of the skin, we use the plastic flat design, yes, to decrease for cosmetic and to the closure the defect.
The length of suture.
With the sutures, yes, with the sutures.
Beautiful.
So in this case, we will use the splint. We will fix both jaws or just
Both.
both. And we will fixate even the opening of the
Yes,
mouth.
yes. For all fracture of the jaw, it doesn't matter, upper, lower, we use the splint technique for both jaws. It doesn't matter. For the teeth, splint. Difference only one. If you can fix with the splint the fractured jaw in right position, you finished. If it's impossible, you give the surgery, osteosynthesis. But we need to fix up and the lower to the right. It helps we can do it only with the splint technique for the both. And then we can use elastics, like the orthodontics elastic, to fix up and the closure. That's all. Yes. How many days patient will treated in the maxillofacial surgery department?
2 weeks.
10 to 2 weeks. Yes, usually it depends. One side fracture, was osteosynthesis, was surgery or no. If no surgery, it's about 7 to 10 days. If surgery was 2 weeks, because we need to control how the patient feel after.
And we will take 3 months to regenerate all this like.
Yes. First, bone tissues present in the area of fractured line after 1 month. Why we use 28 days for splinting? It's for regenerate this, but it's a young tissue.
After taking the splint, you should not eat hard.
Yes.
Hard.
More 2 weeks, more 2 months.
And the splint will be 3 months?
Splint for 28 days for 1 month. Yes. How to control in which period we can take away the splint?
By X-ray follow-up?
Yes. We take X-ray before splinting, after splinting, first before splinting, after splinting, immediately after splinting, and the days, yes, after splinting, because it's the control point to understand finished or we need something else, or we need to prolong the splinting for 2 weeks. Then we control it again and then
X-ray.
take away. Yes, by the X-ray. You use the same type of X-ray. If was CT scan, did CT scan before, after,
To see the same structure.
to see
The same.
the yes.
The difference between
Difference, yes. We need to find it, how it was before, how it was immediately after surgery or after conservative, and how it looks now, after 4 weeks, to analyze the process of regeneration. The same. Because in some cases was the mistake. What was the mistake, for example, was OPG, then the control, or was CT scan, then the control by OPG. This is the mistake. If you want to see it now, you don't have CT scan, yes, you can do it. But for control, for analyzing case report, it's impossible. You need to do CT scan. It's not why you want to take that why patient take money for CT scan, for example. It's for control, and you need to understand the patient why. It's for control.
Doctor, we have to see, it's enough to see just cartilage, or we have to see bone, not cartilage?
First 2 weeks, it will be like a granulating tissue, looks like a cartilage, yes. Then you need to find the structure of the young bone. How looks the bone? Sponges. You need to find the structures. Of course, it's not will be the same like mineralized normally, because it's the adult bone. This is the young bone, but it will be the same structure like normal bone.
So to
Normal bone more mineralized. The area of regeneration, it looks like lighter. You remember how looks the bone? It's the
Yes.
white. Is the white. The line of the fracture, it will be like with the gray color. But you can find why we use now CT scan. You can loop this part and analyze the structures.
So to remove splint, we have to see young bone.
Yes, before.
Okay.
We need to find that the process of regeneration finished, now the process start like the mineralization. And of course, we have the prophylaxis about take care about the oral hygiene, about hard food, about the same discussion with other men about the juice. Yes, finished with this. Because really, it's not hard. Patient feels that it's not the same, it's softer. By the palpation, it's the softer. Because how to growing the bone? Fractured line, fractured line. When then has communication, the growing like this, it's bigger than the size of the jaw. It's forming the cartilage. Then cartilage decrease and change the structure to the young bone. Then here no, but this is softer than real old bone. Then after 3 to 6 months, why the recommendation for the patient, if was fractured there, and here localize the horizontal position of the retained tooth. We wait months before extracted. Because when you drill this to open, to remove the wisdom tooth, you drill the area of the new, and here not finished the full regeneration. Why we need 8 months? If it's easy extraction without the touches of the bone by the bore machine, by the piezo, possible 6 months. If no, wait 8. But you need to analyze the same to control possible or not possible. Because if you use the traumatic operation, they stop the regeneration on this area. We need to finish the full regeneration.
Professor, the same thing if we want to do implants for
Yes, the same. Usually we wait one year, yeah. If it's possible, yes, we wait 1 year. Because they absolutely different. This is the difference. It's not finished. It's not the old bone. You drill, you take away the part of the bone and fix the implant. Usually, the young bone analyzed like the foreign bodies and no regeneration around. It's no, maybe first stability, but no also integration. This is the reason, because it's not it's not performed, it's not finished for regeneration to take the implant. Sometimes yes, we wait more here. Especially if, for example, was not in one, like this one. Especially, not a single fracture. It's maybe 2 or 3 lines of the fracture. Yeah, we wait more. We understand for the patient that it's impossible, but we need that the whole process of regeneration finished. The positive, if no also integration. The negative may be formed the osteomyelitis. It's we lost more bone again. This is the reason why we wait. The same, but it's like the trauma too, because you need to use the technique of right position to the right position, and why you discuss with the semester with the trauma. It's the same like was previous.
Is this location for TMG?
This location of TMG, yes. It's the same.
Like previous,
yes, from one side, from both sides, this line the middle, and how to understand that.
Yes, that's
this
right.
this
Oh,
location,
yes,
and the by Hippocrates technique for the reposition, for reposition. If it's middle, or we can use the Hippocrates technique. If it's distal, we can use the same technique, but the position of the patient is like in the horizontal position.
Yes, sir.
The different technique, but the same for reposition.
Yes, and the second.
ايه برايز دي؟
Yeah, I know, but
It's development that is تدوشي زوبر. When the pressure of the tooth and the tooth don't change the dislocation, but the apical, but the nerve and pulp did. It's like the apical periodontitis. Yes. How to understand? We can see the change of the color of the tooth. Patient feel that the tooth growing and higher than it was previous and that was before. And how to treat? We use the endodontical treatment. Yes. How to control to endodontical treatment? Usually, the patient said that trauma was 3 or 5 days before, and no, nothing. But after trauma, after 3 days, starts the changes. The feeling, no feelings there. First was when was trauma was the pain. Then pain finished, nothing, no edema, no nothing. But the pulp did. And start the necrosis of the pulp and start the apical acute periodontitis. Yes.
and what's the need of classification?
Her classification of dislocation and the fracture we discuss. Full dislocation, separate dislocation, fracture of the tooth we discuss. Fracture of the crown, fracture of the root, fracture in the center of the root and the apex of the root. How to understand by X-ray what we should do. If it will be fracture of the crown, we use the therapy and the prosthodontical therapy to restore the body feeling or to restore by the artificial crown. If it's in the center of the tooth, we remove it. If it's in the apex area, we use endotherapy. And we use the apexectomy to take away the pieces of the fractured bone or of the fractured.
This is the fraction of the root, yes.
Yes. Before we use the endotherapy, yes.
And also fractures of the upper jaw.
3 types
Fracture.
of the upper jaw. 3 types.
This classification.
Yes, for
And
classification.
concept of combined trauma.
How to treat?
How we have answer in this question.
Yes. How to treat if usually all trauma and maxillofacial region combined. It doesn't mean that the fracture of the jaw, for example, or the tooth, and the fracture and the injuries of the soft tissues. And we use this combination of combined trauma.
This is and
Yes. And we use it in the same. We, for example, reposit the jaw to the right position and sutures the soft tissues, the mucous or the skin. And that's mean combined trauma.
you want to do CT scan, MRI, or you
We can use, we need to check where is it. Only upper jaw, only lower jaw, or maybe it's nose, or maybe zygomatic bone and the lower jaw. We can check it by X-ray, and the soft tissues we can palpate and observe by eyes to understand in which region present the trauma of the soft tissues.
and 27.
How many discuss? How the patient look with the fracture? Cannot eat, cannot close, cannot drink. They change the configuration and all changes you can see by X-ray.
And typical fracture sites in the upper jaw and the lower jaw.
Yes.
Like we discussed in X-ray?
Yes, on X-ray. Where will be the typical line of the fracture and why? Angled, ramus or condylar process, and the foramen. Mentale
And one is different
and the
in the
zygoma-
side.
Yes, it depends on the upper and the lower jaw. Or it depends on the softest structures of the bone when 2 lines connection, one sagittal, one horizontal line, and where localize, for example, if the localize the retained teeth, because it's like the empty inside and the tooth is hard, and when when the force given inside, it's like the hard and the fracture go deeper. This is why it's characteristic of the line. That's all. You have a class there.
Yes.
I take the ski. You can take to the doctors. Okay.
Doctor, about the first question, it's
like basic and additional currently special methods. What are we talking about in this question?
We discuss about it. We can use manual, we palpate, walk. We can use your eyes to understand symmetry, and we can use interorally observe the same examination, the same, and additional CT scan, X-ray, MRI, the same. We can use it for all. It's the same like we usually use, but we usually don't use the palpation all structures from
Like
the
with
belt.
special methods.
Yeah, special methods, more speciality for the problem.